Testing. Okay. Well, hello, everyone. You're back. So glad you returned. And I'm sure we're going to have some of our friends slowly migrate. It sounds like they're on their way even now from the fellowship hall. How many of you enjoyed the taste and see table? Yeah, I know I tasted and saw quite a bit. But we're hoping you taste and see that a plant-forward, plant-based diet not only is good for you, but is something that you enjoy. And hopefully you were able to take pictures of recipes and implement those new recipes into your meal planning. If you were here last year for our first celebration of wellness, then our next presenter will not be a stranger to you. We're glad to have Dr. Christopher Keeler back with us for this second year's celebration of wellness. And so he's going to come up in a brief moment to share with us how we can celebrate more wholeness in our bodies, with our bodies. And there will be time for Q&A after his presentation for you to bombard him with some questions, and we'll see what wisdom and advice and counsel he may be able to help you with your particular concerns. But if you have had a wonderful day here, please let someone in a green shirt know. If you have any observations as to how we can make this event better, please let someone in a green shirt know on our team. So we want to improve this and continually make this a blessing to our community to experience more health, wellness, and vitality. I want to thank those of you who donated to our blood drive. And if all goes on schedule, this presentation should end around 2:30-ish. The bloodmobile will be out there until 3. So if you get in there, that little window of time, they'll stay until they draw your blood. And so you can add to our count. Now, I'm hearing, this is what I'm hearing, that we are trending to reaching our goal. Now, some of you may be thinking, well, if we're trending to reach the goal, then maybe my blood is not needed. Well, remember, there's someone out there who's going to have an accident, a surgery, an emergency that could use what you give today. So don't let the fact that we're hitting our goal or coming close to hitting it persuade you to not participate if you can, because there's someone out there who needs you and who would appreciate to the moon and back what you can do today. And if that doesn't persuade you, we had a blood drive not too long ago where we went under our goal. So if you participate, you can get us back to 100%. Because I've only had one blood drive here where we did not reach our goal. So if you can put us back on average if you participate and we go way over our goal, we'll be 100%. Enough of that. You're here to hear Dr. Keeler. So would you please give a warm welcome and a round of applause and welcome him as he talks about celebrating more wholeness of our body.
Thanks, everybody. Can you hear me okay? Okay. If I need to speak up, just say so. So I'm Dr. Keeler. I'm a board-certified general surgeon. I work at Advent Health Waterman. And I did my medical training at Michigan State University College of Osteopathic Medicine. So for those Michiganders that are in the crowd here, we get a lot of Michiganders come down to Florida. So yeah, absolutely. You know, they had a lousy football season this year, but we always have basketball. So I appreciate the warm welcome and the invitation to come back for my second visit with you guys. It's my last year we talked about colon cancer screening, and it was a really good experience, and I appreciate the invitation to come back. Today, I'll see if I can get the clicker to work. A lot of times when I introduce myself, I'm a general surgeon, and everybody wants to know, what the heck is a general surgeon? I mean, everybody knows what an orthopedic surgeon is, or a urologist, or, the cardiothoracic surgeon. But the general surgeon, a lot of people don't know what that is. So allow me to take just a few minutes to kind of share with you a little bit about my training and my certification. So general surgeon, we kind of cover everything. And so as you'll notice on the screen up here, I just put a couple highlighted items there. Obviously, we have to know the anatomy and the physiology of the human body, but it goes far beyond that. From the metabolism, the nutrition, immunology, pathology, wound healing, it's a big one. We also train a lot about shock and resuscitation, because often inside the emergency department, when you have a trauma, at a large level 1 trauma center, you have trained trauma surgeons that come in, but we're also trained under those same training guidelines, but we often will work in the smaller community hospitals, so it's important that we know how to resuscitate our trauma patients. We also often will work in intensive care units. Usually it's the surgical intensive care unit. And we also do a lot with cancer patients. So there are 9 particular areas that you'll see a general surgeon, work in. So the alimentary tract is basically your gastrointestinal tract. From the mouth to the behind, anything in between in that tube is fair game for the general surgeon. So, but we also deal with the abdominal organs as well: liver, spleen, gallbladder, pancreas. You kind of get the idea. We kind of do a lot of those things as well. We do a lot of breast cancer work. We do a lot of soft tissue. Sometimes you have lumps or bumps all over, and the doctor says you need to go see a surgeon. You'll get sent to someone like me to help with that lump and bump. Head and neck, that excludes trauma. As you'll notice, we don't do a lot of the neurosurgery. We don't do cardiothoracic surgery. We even do a little vascular, but when it gets too much, like the main aorta, we refer to our vascular surgeon colleagues to help us out with that. But surgical oncology, we do breast cancer, colon cancer, some gastrointestinal cancer. We do trauma and burns, and then, of course, critically ill patients. So you can see it's kind of a smorgasbord. For me personally, I'm one of those guys that likes to do a lot of things. I kind of get bored doing the same 2 or 3 things over and over again. So you could see why this specialty would appeal to someone like me, because I like to do a lot of different things. I wanted to spend today and talk about hernias, because in my line of work, and especially in this community, we get a lot of them. And so as part of the whole body wellness, it's important that we understand how our body works. It's important to know what screening things we can do to prevent disease. Well, hernias is a big part of that. Raise your hand if you know somebody or personally have had a hernia before. I mean, it's like 80% of the room here, so you see how common it is. So just a quick definition of a hernia: it's an organ or a tissue that herniates through a body cavity, usually through the muscular layer of the body wall, and it results in bulging or swelling or pain in that. The most common is obviously the front of the abdomen. It's the most visible part of our body, so we can clearly see it. But there are other parts of the body where we can have a hernia, and we'll talk about that. So I just decided to bring up some of the more common ones that you may have heard of, but there are about 24 known abdominal, pelvic, chest wall hernias. So some of them are very rare, but these are just the common ones. So within the groin, there are several spaces where we can get hernias. Specifically, when we talk about the inguinal, there's the direct and the indirect, but also the femoral. That's a canal where the femoral vessels leave the body, the pelvic cavity, and go down into the legs, and that space you can develop a hernia in. The ventral, the front part of the abdomen, that's a common place to get hernias. So above the belly button, we call it the epigastric region, or at the belly button, we get umbilical hernias. If you've ever had surgeries in your abdomen, you can develop a hernia where the surgery occurred. And then, of course, at the diaphragm. So these are kind of less common, but sometimes you may have been told if you have reflux that you have a hiatal hernia. And these are also reasons that people come and see me. So just a couple quick facts. We'll focus on groin hernias because these are the most common that are seen. But as you notice on that slide there, men are more likely to get groin hernias than women. Anybody know why? They do. Yes, they do. They're not really good to their bodies. I hear that a lot too. They don't listen to their wives. So, but actually, it's because when we're in the womb and we're gestating, our reproductive organs leave our cavity, the pelvic and abdominal cavities, and they come out, and they're now external. In that process, they have to leave through a muscular wall, and it naturally forms a canal, and that's where men are most likely to get hernias, is in that anatomical canal that's physiologic. It was made during gestation, and because of that, we are more likely to get groin hernias than females are. However, females still get groin hernias. They usually develop hernias in their femoral canal, because we all have femoral arteries and veins that go down into our legs. And there's also a little small opening in the pelvis called the obturator space, where we can get obturator hernias. So you notice that that's why men get most of those, but women can get them too. So when we have hernias, we're most likely going to be at our primary care doctor's office, and we're going to say, hey, I noticed that I got this strange lump. So about 1.6 million hernias are diagnosed every year by primary care doctors. And of those, about half have surgery. And we'll go over some of the reasons why. So I asked, that question about why is that, that men get them more, and you answered because they lift more. So you'll notice that these are the 7 most common reasons why people get hernias. And obviously, if you're doing a repetitive activity, even if it's 25 pounds, just doing it over and over, day in and day out. So somebody might have an assembly line job, or whatever they do at work, it's a repetitive motion or repetitive activity. Those kind of things can lead to hernia development. But prior surgeries we talked about, who would have thought that having allergies where you're sneezing all the time, or you have underlying lung conditions where you cough all the time, would predispose you to hernias? I bet most of you didn't know that. And that's a really common one. A lot of lung patients with COPD or our smoking population will develop, because smoking causes the tissues to be weak, but it also induces that cough. And if you're doing that every day, day in and day out, you're most likely to get a hernia. So other things to consider there is pregnancy. Why pregnancy or why obesity? Because it stretches the tissues. So my wife is an OBGYN, and all her challenges she faces after 4 kids, she just says, this is why, this is the sacrifice I made, right? Is now I have a hernia, now I have hemorrhoids, now I have varicose veins, now I have, thanks children, So there are a lot of things that will contribute to the body changing over our lifetime, and that's just what it does. The body is designed to change. The other thing that's not on there, and it's a reason, is age. As we get older, our tissues just aren't as strong. So we might have some challenges that we're born with, but as time goes on, then all of a sudden they manifest later on in life, and a hernia is just like that. You just randomly are doing something one day, all of a sudden, bam, you got a hernia. It's like, where did that come from? Well, it's probably been, taking a long time to develop into a hernia, and then it just manifested. So, common symptoms. These are not the only symptoms that you can have, but they are the most common that patients will come into the office, or, husbands complaining to their wives, I got this bulge and it won't go away. But bulging or pressure, a lot of people will feel pressure in their groin space or in their abdomen. A hernia doesn't always have to just have a bulge or swelling. Some of the early symptoms people will feel is like a weird pressure or heavy sensation. Some people can feel a little burning sensation, maybe a dull ache or pain. But usually when it really gets a bulge and then it really hurts, then you know something's up. That's usually why the guys come in, okay? It's so big and so painful they can't take it anymore. How long have you had that? 10 years. Why did you wait so long? Well, it didn't hurt till yesterday, So a lot of times you will probably have a good idea based on how it looks, a bulge, or how your symptoms are, that you probably have a hernia. And you're saying, I just don't want to go to the doctor. Eventually, if you're a guy and your wife's tired of complain, and she'll drag you into the doctor's office where they're going to do a physical exam. And a lot of times the physical exam is all you need to make a diagnosis. Other times your exam might not be really clear. It might not be obvious that that's what you have is a hernia. So oftentimes other testing will be done. Now, for hernias, my choice of image is an ultrasound, and I like them because they're cheap and they're good for the patient because you can move around, and we want you to. I like to know on a hernia if you've got tissue that's kind of slipping in and slipping out of the hernia defect. If it's not inside the defect, when you get a CAT scan, it'll say you don't have a hernia, but on ultrasound, it'll slide in and slide out, and the ultrasound tech can tell you cough or bear down or wiggle or move, and you can. When you go to a CT or MRI, you're like, stiff as a board. They tell you not even to breathe, so it makes it a little harder. But a lot of times patients are referred over because you are going to a doctor for another reason. Let's say somebody was looking at your kidneys, and then you go to your urologist to follow up, and he said, hey, by the way, did you know that you also have a hernia? And I had no idea. And we have what's called an incidental finding. That's not why you had the CAT scan or the MRI, but it did find that you had one. So that's often how hernias are found. So you have one, you see your doctor, they want you to go see somebody. And really, I think that's probably, if you know of somebody, or if you are sitting here and you have one, but you haven't actually talked to somebody, it's a good idea to see your primary care, but it's a better idea to talk to somebody like me so we can give you all the options. Because sometimes that's where the power is in medicine, is sitting down and talking to the doctor or surgeon who's actually doing the procedure, so that you get a chance to kind of know what exactly all of your options are. And so that slide where we showed 1.6 million hernias are diagnosed every year, but only 800,000 of them are fixed. The question is, well, why didn't they all get fixed? I thought all hernias needed to be fixed. Well, from a surgeon's side of things, I like to recommend that, because oftentimes those that maybe don't can develop a worse situation, and we don't want that. But not everybody may want surgery, or maybe you're not even a good candidate because of an underlying heart condition, or you're dealing with something else that we fix something else first before you come back and you have that. And so it's always good to talk to somebody like me to get your options. So the options really are, this is an incidental finding, I have no symptoms, life's really busy right now, I'm not really bothered by it, I'd like to wait, which is an appropriate option in certain situations. It all depends on where your hernia is, what's sticking out of the hernia. A lot of different factors go into that watchful wait. But oftentimes patients will come and they have had the hernia for some time, and they're at a point now where they would like to get it fixed. So the idea is to sit down with somebody like me and go over what your options are. Because sometimes, in fact, I had a patient not too long ago, he said he put off his other hernia for 10 years because of how his hernia was fixed 10 years ago. And they made a big incision, it was a tough recovery for him, and that was his experience, so he didn't want to do it. Well, the evolution of medicine right now is changing very quickly. And not only do we can use the traditional open, make an incision and fix things, but now we're doing things more minimally invasively with smaller incisions and better technology, that gentleman's concern didn't need to be there anymore. He could sit down with me and we could resolve that concern by showing him other ways in which we could fix his hernia. And so that's another benefit of sitting down with a surgeon to go over everything. A couple pictures here. I don't know this, because it is kind of far away, I don't know if you can really see. The picture on the left there, the guy has a large incision down his midline. He also has a large incision in his groin over here. And he now has a new bulge in his right groin. And he wants to have surgery to fix it, but he's really nervous because the hernia here, they fixed through a large incision, And the hernia over here, they fix with the large incision. And he's not sure he wants to go through that again. The picture on the opposite side, on the right side, is a groin hernia that was fixed through 3 little incisions. And the picture in the middle is what that looks like. And these are just 3 examples of hernias in the groin: a direct inguinal, an indirect inguinal, and a femoral hernia. And then you'll notice that there's a piece of mesh that covers over that. One of the things that patients want to know is, I always thought you guys closed the hole. In some spaces we do, the diaphragm, the front of the abdomen, things like that. We can bring those tissues back together. In the groin, not so much. Trying to close that defect, there's too much tension. It's oftentimes ligament, not necessarily muscle. You try and pull that together, it's just going to break, cause pain, reoccur. So with groin hernias, it's always mesh. And then that brings up a whole nother. How many have heard commercials about the dangers of mesh, right? Another reason to sit down and talk to surgeons like me, because a lot of the products we use are not those products. Remember, they've been taken off the market. But there are all kinds of meshes. I mean, dozens of types of mesh. So it is important that if you're talking about a surgical option that does involve mesh, that you get a chance to actually feel the mesh. I have prototypes of mesh that I let my patients handle in the office, so they get a chance to see exactly what's going to be put inside of them, and then to know all the pros and cons about it. So again, it's really important to talk about. So starting on the left side there, that's just your traditional, you got a hernia, make an incision, you go down, you fix it. And then about the 90s, we saw the evolution of laparoscopic surgery. That way you could do a camera, some small incisions, you have all these instruments. What a lot of people don't realize is when we're in the operating room, we've got a whole team of people in there. There's usually 5 people in the operating room. You have your anesthesia, the surgeon, and then you have 3 support staff, sometimes a nurse circulator, so maybe 6 people. And those other assistants are helping me do the surgery by holding retractors or holding instruments. With laparoscopy, I need a whole team of people to help me with all these instruments. If I make 4 or 5 incisions, I need other hands. I've only got 2. Now we've evolved to robotics. So in the early 2000s, a company by the name of Intuitive developed a robotic system called the Da Vinci robot. 18 months ago, Advent Health Waterman got their first robot. And we've been doing a lot of robotic surgeries using that platform. I'm proud to say we've just purchased another one, so now we have 2. And we're expanding that not just in the abdomen with hernias and gallbladders and colons, but cardiothoracic surgery. We'll be able to have heart procedures done through little incisions. I mean, it really is a wonderful resource platform technology. Now I don't need to have so many people in the operating room because the robot is my assistant. It will hold my instruments while I control it. And it is quite remarkable. And if you haven't, I really wish I had had a video. But you can look up the Da Vinci robot system. Just Google it. There's wonderful videos and things. It's just a really wonderful. I'm really glad that we have that in our community because it really does benefit our patients. So we talk about, we can use small incisions to give big results. One of the benefits that I think the technology offers patients is a faster recovery. We've all heard about the opioid crisis that's kind of really crippled the United States. Back in the 90s, you could go to your doctor and they'd basically give you a whole bottle of narcotics. Take these, you'll feel better. And maybe that was too much, So we've had to really look at how do we make incisions, and I know I have to hurt you to heal you. It kind of sounds like a weird, come to me, I'll hurt you, and then I'll heal you. But this technology allows us to make such a small footprint in spaces that don't have a lot of nerve sensitivities. And we can do a lot of work, and then afterwards patients have almost no pain. And it really is remarkable that patients will come to me and they say, you know, you sent me home with 8 pain pills, and I took 2. And then I just used Tylenol until I felt completely normal again 3 days later. These open incisions take weeks sometimes to feel better, feel normal. The bigger the incision, the more likely that you're going to get a hernia, because those tissues, that scar tissue, isn't as strong as your normal tissue. With small incisions, you're not at risk for getting hernias because they're so small. So, I mean, there's such a, the evolution of this has become so wonderful, and I really am privileged to be a part of the growth of the technology in medicine. So I just wanted to let you guys know that over at the general surgery practice at Waterman, myself, Dr. Smith, Dr. Tran, we're all board certified general surgeons in the group. We're all accepting new patients. We take care of patients 18 and above. A lot of times patients want to know, well, how can I come and see you? Well, there's a couple ways. You can call your insurance provider to find out if you need a referral. If you don't need a referral, you just pick up the phone and you call and come in and see one of us. If you do need a referral, you just go to your primary care doc and say, there was this ugly guy that came to the Adventist church, and he talked to us about hernia, and he seemed like a nice guy. Maybe I'll go see him. And you more than welcome to do that. And sometimes you just don't know. You want to get some information. You want to be screened or have a consultation. That's what we do. Just because you're coming to see us, it doesn't mean you're going to walk out of there having an operation. But if you need one and it's right for you, we would be happy and honored to take care of you. So there's a QR code. You can scan that if you want. I'll leave it up. But I want to just take the remainder of the time and just answer any questions you guys might have about hernias or any of the things that we've talked about. I've got a couple mics here. Yeah. Questions?
Kind of close, so do they ever heal on their own? I
Hernias?
don't have one currently, but I was just curious.
It's a good question. So the definition of the hernia is that there is already a defect. And the defect is within the muscle of the body. And that muscle defect, it won't close up on its own. And so usually what happens is once a hernia is there, the longer it stays there, the bigger and worse it will get. So they never will close up on their own, but you might have one that doesn't give you any symptoms. And so a lot of times people say, well, they had one, they told me I had one, but I never had any symptoms, so it must have just healed on its own. It's still there, it's just for whatever reason it's stable and it's not giving you any symptoms, and so out of sight, out of mind kind of thing. But they don't. Once you have one, unless you get it fixed, you'll always have one.
Yes, doctor. You mentioned MASH. I'm not that much familiar with that, but you use that in hernia to close the area. Is that what a MASH is for? And what's the pros and cons of using a MASH?
Good question. So yes, not every hernia is the same. You could have a groin hernia, and he could have a groin hernia, and they're going to be completely different. And one of the reasons that we do use mesh is to act as a reinforcement to the tissue. And I mentioned earlier, there are lots of mesh products. Some of them are designed to absorb and dissolve over time. Most are permanent. Some are synthetic. Some are actually biologic. We use sometimes cadavers or pig or cow. And certain meshes need to be used in certain areas. So it's not just uniform. Not every mesh should be used for that one hernia. So we tailor the type of mesh, to the type of surgery, to the type of patient. A lot of these meshes, especially the synthetic kind, it's just polypropylene, so it's just plastic. It's been around more than 70 years, it's been in use. And so we kind of know that, the human body accepts it, but maybe you have a specific kind of physiology and your biology doesn't like polypropylene. So one of the risks of mesh is that you might have a mesh rejection. Most of those would be more common with biologic meshes, like from a cadaver or cow or pig. You might see rejections from that. But really a mesh con would be, it can cause scarring. So we really have to be careful where we put the mesh, because that's one of the reasons you saw commercials about, if you've ever had a mesh, call the law offices of so-and-so, we'll be happy to fight for you. Because a mesh was used in a way that it wasn't intended for. And as a result, it caused scarring to happen with organs, and those organs then develop problems because of the mesh. Mesh could also cause pain. It doesn't mean it will, but that's one of the risks. So mesh can also not handle infections very well. So it depends on how porous your mesh is. They make microporous meshes and macroporous meshes. These are why it's important to sit down with the surgeon to go over these things, because you all have really good insight into your own body. And it's not like this is too much to understand, but you could understand why it would take a little bit of time to sit down and go over these concerns or questions, so that hopefully it prompts, like the questions we're getting today, going over the discussion, it made me think about that. So there's a lot to consider with mesh, but hopefully those are just some of the general answers that would help you with your question. The one thing I didn't mention in the slide that just made me think about this is about 10% of hernia repairs that occur in the United States will recur in the first 3 years. So that's irrespective of the surgeon or the hospital or the technique or the city or state. Across the board, we track all hernias in the United States, and on average, 10% will reoccur in the first 3 years.
I have two questions.
Okay?
The first one, can you get an abdominal hernia from having a baby when you have a baby?
You can.
Okay. No.
Can you get an abdominal hernia from pregnancy?
Yes. Now, if you have that hernia fixed, how would you know that 10%, how would you know that that occur? Yeah.
So a lot of times that recurrence will happen the same way your first hernia started. You'll have some pain, some swelling, maybe bulging. You go see the surgeon. The surgeon says, well, we should get some pictures to make sure you don't have a recurrence. And the pictures usually help identify whether there's a recurrence. But I think one of the questions back there was, well, why does that happen? I mean, if you guys fixed it, you should be good at your job. Why is this happening? Well, the interesting thing about the human body is it's very dynamic, and everybody's body is different. But everybody's ability to heal is a little bit different. But those factors that we talked about of why people get hernias still play a part in how a hernia repair is, stays intact. So patients who still smoke after hernia repairs, if you've had a hernia repair and you gain weight, the weight gain will put tension on that area, and it can cause that to reoccur. My construction workers, my mechanics, my landscapers who are 30, they come in, they're doing a hard job day in and day out. They get a hernia repair, I tell them, change your job. They don't want to hear that, but they'll always be back with another hernia. They're just putting too much stress on their body. They had a hernia to begin with because of that. But so we try to work with them, say, you know, try these preventative measures. Sometimes it's wearing belts or trusses, or trying to avoid doing a lot of that strenuous activity, maybe getting a second person to help when you do things that are too much. But at the end of the day, I mean, we all have to support our families and do what we have to do to get by. But I think the most important thing is that you actually sit down and have that one-on-one conversation with the surgeon. You know, if the patient understands that there's a lot of factors that can predispose a patient to hernia, and I've gone over and said, you know, hey, you might be one of those risky patients, please try these things. And then the patient comes back and says, well, I think I have a recurrence. You know, at least they were aware of why things like that would happen, you know. But again, 90% don't. So those are still pretty good odds. I mean, if Vegas offered me a 90% chance that I would win on Red 7, then I'll play it, you know. But a lot of these, we're trying to help a patient in their time when they've had, their body has changed and they have a problem. And so we try and do everything we can to restore patients back to their normal self as much as possible, knowing that there are some limitations. So, other questions?
I just want to know if you have a hernia, the height thing.
By your diaphragm?
Yeah.
Uh-huh.
Could that be cured with a certain diet, or do you eventually have to have surgery?
So she was asking about having a hernia at your diaphragm. And like all hernias, they occur through a muscle layer. And once that muscle layer's been stretched, it will never return to normal. So, but it doesn't mean that, you know, I get a lot of people will come to me and they have a very small diaphragm hernia. And for the most part, maybe they just discovered it incidentally, or they were having heartburn. You know, most people don't realize that one of the contributing factors to reflux is that you have a hiatal hernia. And so depending on your symptoms and what's happening in your life, maybe you decide, this is bothering me so much, I would like to get it fixed. Other people, it's just like we mentioned, I got a study for something and then the doctor came and said, oh, by the way, did you know? And you're like, well, no, because I have no symptoms. They usually get referred over just so we can sit down and talk about. These are the things you should expect. These are the things you could do to try and prevent symptoms, and you just go from there. So usually what I find with hernias is that a good weight and a good diet can help reduce symptoms, but it will never undo the problem that occurs at the muscle. You got a hole there. Other questions? Yes.
You'd mentioned recovery time. What is that? And also, some hernias are so slight. What's the procedure to follow on that?
Okay, so 2 questions there. So one, what's the recovery like? So the recovery depends on where your hernia occurs and how it was fixed. But generally speaking, when you see the surgeon, you're going to hear this 4 to 6 weeks. And everybody's like, well, I can't lay in my bed for 4 to 6 weeks. That's not what we mean. Generally, what I tell my patients is, I expect you to have some symptoms from the surgery for 3 to 5 days. After 3 to 5 days, you should be able to walk around your house and basically be normal without even feeling pain. What we want you to do the long term, that 4 to 6 weeks, is, remember all those risk factors? Don't do any of them. Okay, so no lifting heavy, no pushing heavy, no pulling heavy. So that's 20 pounds. That's the limit for 4 weeks. No smoking. Got to lose weight. So a lot of times people hear that 4 to 6 weeks and they're like, I can't take that kind of time off work. And that's not what we mean. We're really, the recovery, what I think most patients ask, what they mean by what is the recovery time is how long should I expect to have pain and discomfort? And with the new robotic platforms that we're using, it's 3 to 5 days.
How long before you can start bucking hay,
Yeah.
like that?
Yeah, so
what causes
returning to your regular life is 4 to 6 weeks. Now, a lot of my farmers, so I was practicing in Oregon before I came here, and we were in eastern Oregon, which is part of the grain belt of the Pacific Northwest, so a lot of wheat and a lot of agriculture, and a lot of my patients were farmhands. And so they're coming in and they're asking, well, my boss needs me back to do all this physical labor. And it's like, oh man, like you really got to be good because you're doing that day in and day out, and that's a risk factor, So the reason because I've had patients ask me, did you guys just make up the 4 to 6 weeks? You had nothing better to do. I like this guy, he's 4 weeks. I don't like you, it's 6 weeks, It seemed very arbitrary, but the reason for that is when we started using mesh, it takes about 30 days for the body and the mesh to incorporate, so that membrane that's being made by your body forming the tissues into the weave of the mesh, it takes about 30 days to do that. So hence 4 weeks. Bigger repairs, higher risk. Maybe you're the third surgeon a patient's seen to fix the same hernia. So they've had it fixed 2 other times. Well, you just got 6 weeks, because you're at higher risk. So there are a lot of those factors that go in, but, and then what was your second question?
Well, some hernias are
Small.
slight. Normally, do people just wait on that, or?
A lot of times they do. A lot of patients, age has a factor, cost. I mean, we have to be honest. In our economy, things are really expensive. So, when patients come to me, I have to be aware of the cost that this patient is going to incur as a result of a surgery that I may do for them. And so a lot of times it's not the right time for the patient. So they'll come in and say, Doc, I really want this fixed, but financially I can't do it right now. I totally get it. Let's follow these instructions. Let's do these things to see if we can push it down the road until it's a more attainable thing for the patient. And some patients that works. Others, they just can't. Their symptoms are too problematic and they can't wait. So sometimes we just have to do what we have to do in those situations. But I just want to let you know that the surgeons are aware of all these things. I mean, we all have lives and we all have things that are going on. We all have costs, and it's really important that you sit down and you have a chance to express those concerns to your surgeon, because we understand and we are happy to work with the patients, but we will also go over, well, if you choose this, then these are the risks, and if you choose this, this is the risk. And as long as both parties have an open conversation, I think that's where the relationship building comes, is having a chance to sit down and talk to your doctor one-on-one, just like you would with a friend, no pressure.
Quick question. We talked about weight-bearing exercises. Now, does that causes hernia?
So, are you talking about like if you're going to the gym and doing that kind of stuff? So, really good question. I think it's great in our society right now that most of us are conscientious of why exercise is important. And I have a lot of patients, retired patients, that are coming to my office and they're saying they're going to the gym 3 or 4 days a week. And I'm like, that's great. But they have a hernia and they want to get it fixed. And they want to know, well, can I go back to doing some of these activities? What I have to remind them is certain activities cause a little more strain in your abdomen than others. What a lot of patients don't realize is that in the abdomen and in the pelvis, it really is a fixed compartment. So when you add more pressure into a fixed compartment, there's no room for anything else to go anywhere. And have you ever taken your kid's Play-Doh and put it in your hand and squeezed it? And the Play-Doh starts to come out of all the little holes? Well, imagine these little holes are the little hernias that you're having in different parts of your pelvis or abdomen. And every cough or sneeze or lifting or strenuous things you're doing, imagine that's your abdomen squeezing down on your organs or your Play-Doh. Eventually that weak spot is going to give way and you're going to have fat or bowel or something squeeze out through that defect. And so it's okay to get the exercise. I tell my patients at 2 weeks they can get on a stationary bike, they can do elliptical, they can run, they can swim, they can do a lot of those things, but I don't want my patients going back and saying, hey, I'm 75 and I want my six-pack back. Ain't gonna happen, you know. But you can go to the gym and do some free weights. You know, the new trend is light weights, mini reps, right? And that's a good thing because you can still build muscle, but you're not doing the, you know, while you're at the gym. We don't want that straining. That's that pressure in the abdomen that's forcing tissue to weak spots. And then because it's weak, it's the weak link. So you'll get a hernia. So really good question. It's okay to get back and do exercise and activity within reason, you know.
You talked about what mesh was made of, but what does it look like? Is it like a screen or is it a full sheet of?
Really good question. So the mesh, he wanted to know, you know, what does it really look like? And I think the best analogy is a chain link fence. So it's a weave cross pattern, and they have coated meshes. And so on one side, we have an anti-adhesive. So if it's going to go in your abdomen and it's going to sit next to your bowel, we want that anti-adhesive barrier so they don't stick together. It's still a weaved mesh, but it's got a coating on one side. And then some, like that we use in the groin, for groin hernias, it's actually pre-shaped to fit the curvature of your pelvis. So it comes and it looks like a round half disc. And it's contoured specifically to mold the patient's anatomy, and it comes in various sizes. So when we're doing your hernia repair, we actually take measurements and fit a mesh to your anatomy. And so some sheets, they come in square, like pieces of paper, and we can cut it into a shape to fit a particular kind of hernia. Some are already pre-shaped. Like if I know I have somebody with a large hernia here, it comes in like an oval. And so there's lots of different configurations, types, styles. Some are completely solid, no pores, no gaps. And some, we prefer the ones with gaps. They resist infection a lot better. Some are already impregnated with an antibiotic. So it's important to know if you have antibiotic reactions or allergies, because we wouldn't want to use that mesh, you know. So lots to consider. Hence why your regular doctor can't just sit down and talk to you about it, because I'm still learning about all the mesh products that come out all the time, you know. So these are all really good questions, and having a conversation with a surgeon is the best way.
If you already have mesh from having some type of surgery like that, is there a recommended amount of weight that you can or cannot, should or should not lift?
So she's mentioning if you've had a hernia repair and you already have mesh in, are there restrictions? Should you not lift or do certain types of things? So long term, after that 6-week period, we basically tell the patient, you know, you've made a full recovery. That new membrane and that mesh should retain about 95% of the original tissue strength. So yeah, generally speaking, I mean, you can go out and, you know, your tire's flat on the freeway and you have to get out and change your tire. Obviously, that's going to be a little bit of work. You're not going to get a hernia from that. But if you are doing that every day, over a 5-year period, chances are you're going to put a lot of stress on an area that isn't as strong as the original tissue, and the weak link always fails. So the repetition, the amount, the frequency, those are the things that when you're straining day in and day out doing something, you're going to probably get a recurrence. And that's why coughing is so devastating for patients with hernias, because that cough is it's just that chronic. I mean, think about it. You could cough 30 times a day, and that's an enormous amount of force in a fixed compartment, always pushing on the weak spot. And you can see that that would cause a problem. So a lot of my lung patients, we ask them to see a pulmonologist. We try our best to get their cough under control. As long as they're aware of the risk, it doesn't preclude them from having a hernia repair, but they need to be aware that they are a high-risk patient for a recurrence. Yes?
Have you tracked the infection rate between having a bunch of people in the room versus having less people with robotic?
With robot or?
Yeah, because you said you didn't have as many people in the room with the robot.
Yeah, so we do, but you know, a lot of these staff are versatile. We'll just use them in other areas. But yeah, I mean, it's usually one less person in the room for robots. But the thing that patients don't realize too is that when the surgeon starts a case, let's say your surgery took 5 hours. I didn't leave the room for 5 hours, but everybody in that room left to get a break or do something. So, you know, that's things that patients don't realize, is that people are always coming and going in the room, and that's why it's really important that we all follow those sterile techniques and they know how to do all that, because I need people that know how to do everything in that room. If somebody's coming in to replace that one, they know how to do everything. So if we ever need something, the person that came in knows exactly what to do. So we still use them, but yeah, we do track all that, you know. So all that data is tracked.
So as a general surgeon, do you do pilonodal cysts?
Yes.
Could you
Different
tell me?
topic.
Yeah, it is. It is. So maybe I could talk to you a little about it later.
Yeah, I mean, you can scan.
Sure.
You can. I don't know if Dom, do we have any of my cards or anything? So blue shirt, Dom, in the back. Just pick
I
up a
got
card.
it.
Okay. Yeah, come see me. Do you had a question?
Would there be any reason why a surgeon, after examining you, tell you that you don't need one?
You don't need.
You don't need surgery?
So there are patients that come and see me, and they have absolutely no symptoms. And then we start talking about, tell me what you do every day. And the patient, maybe they crochet. And I do. I mean, I have one patient that is, my daughter wants to learn how to sew. And she's like, well, I teach classes. So it worked out great. But she doesn't do a lot. So she's like, well, I'm not straining. I have no symptoms. I don't cough. I don't smoke. I just I sit in my chair and I crochet. Well, her chances of having troubles with her hernia that she has is very low. And she came to me because her doctor made her come, because on a CAT scan it showed she had a hernia. She's in my office saying, why do I need to be here? And I said, for information. It's the only reason you're here. I'm not going to make you feel bad for having a hernia. I'm not even going to make you feel bad if you don't want to get surgery for me, or period. But some patients, just for all the factors that we talk about, some are better at watchful waiting than to just rush them off to a surgery. Because the thing with the surgeon, anybody in this room can learn what I do. But the hard part is having restraint to know when you shouldn't do a surgery. So it's matching the right patient at the right time with the right surgery that will benefit the patient. And having that time with the patient is crucial, because maybe it's not going to be what is right for them. Now, the patient sometimes says, well, I don't care, doctor, this is what I want. At the end of the day, I work for you. So if that's what you would like, but it's not uncommon with an asymptomatic hernia, patients not at high risk for problems, that you do the watchful wait and say you don't need a hernia repair at this time. But it doesn't mean that we can't revisit it in 6 months or a year or 2 years. Because once you've had surgery, you can't go back. So sometimes it's better to just wait until that time, and then we can decide to do it, than to just say, oh, well, you're here, I have nothing better to do on Thursday, let's go on a date to the OR, you know. And so that may be one of those scenarios. But remember, at the end of the day, if you didn't have a good experience with a provider, you didn't think you got the information that you needed, you were unhappy or unsatisfied in any way, guess what? You can go see somebody else. So you can always come in for a consultation. That's never a problem. So I would encourage you all, if you have questions, if you know somebody that has a hernia, you hear in those conversations with a friend, well, go see this guy, Dr. Keeler. He'll sit down and talk to you about it. There's no pressure. We don't make you sign anything. It's just information. And if you decide that it's right for you and we decide that that's the best course of action, then that's something we'll decide together as a team. Because at the end of the day, we are neighbors, we are friends, and we've been asked to care and love each other. And that's what we strive to do every day at Advent Health Waterman. And I appreciate the opportunity to come and talk to you guys today, and I hope it was informative and helpful, and God bless. You bet, thanks.
Thank you so much. Can we give another round of applause? Appreciation. I can tell you that we have reached today's goal for the blood drive, because I was the 10th person who donated. The person who donated in front of me, it was dehydrated and they couldn't get any blood out of them. So that happens from time to time. We have 2 more people when I left who were doing their questionnaires and getting their hemoglobin checked. So if they are well hydrated and can give, we will exceed our goal. It's still not too late. They're going to be shutting it down at 3 o'clock. So if you still want to donate, or if you were planning on it, I'm not discouraging you. You still have time. The celebration of wellness officially ends at 3 o'clock. So if there's more food, get it. If there's still people doing screenings and you haven't gotten a screening, please do. If you have a green shirt on, like I do, would really love to powwow with you and have you come back here at 3. If you have to leave before and you can't powwow and have a little meeting with me, my green shirt volunteers, be sure you leave the green shirt. Don't take it home with you, and if you do by accident, make sure you bring it back to the church. The shirts don't belong to us. Thank you for coming out. Hope you had a great time. Hope you learned, were inspired, blessed. That's what this is all about. We strive to be a blessing. Yes, ma'am. Uh-huh. Okay. It wouldn't hurt, because we use them every year for this event. The more shirts we have, that means the more volunteers we can have. So if you want to bring it back, that's fine. Yeah, we appreciate that. All right, well, this portion is over with. And again, green shirt volunteers, if you can be here at 3 o'clock when we officially end, we need as many people to stick around after it's over, because we have another church worshiping here on Sunday. So we need to make sure that we clean up the facility together. And if you can stick around after 3 to help, wonderful. If you can't, if you're spent, I understand. Just make sure you leave the shirt behind before you leave. God bless.